Okay guys, so what we're going to be talking about today is an introduction to mechanical ventilation. So the goal of this lecture is to establish a basic working knowledge and outline the fundamentals of mechanical ventilation so that those with little to no experience can have a greater level of comfort when treating these patients, as well as providing a framework that can be used when initiating ventilator settings on the intubated patient. So by the end of this lecture, the viewer should be able to describe what mechanical ventilation is, explain common terminology and abbreviations, know the different modes of ventilation commonly used in the pre-hospital environment, possess an entry-level understanding of mechanical ventilation and how to initiate ventilation, and know common ventilator alarms and their causes, as well as how to correct them. Okay, so what is mechanical ventilation and why is it so important? So mechanical ventilation is a therapy that's used to move gas to and from the lungs from an external device that's connected to the patient. So it's important to understand that normal respiration is a negative process. When we sit here and we breathe in, that is normal. That is normal ventilation, and that is a negative process. So when we add a ventilator to the equation here, this is positive pressure, and there are some physiologic changes that take place when using positive pressure. We're going to get into that when we get into this lecture. So modern mechanical ventilation is something that we're using to assist or replace spontaneous breathing. Now, we think that modern ventilation is, or that this is something that's new. That's, just within the last 100 years or so. And that can't be more false. Now, mechanical ventilation's been around for centuries, as far back, to ancient civilizations like Egypt and Greece, where they understood that somebody that was having any type of respiratory distress, that if they were to give them more oxygen, whether that was blowing through a reed into their mouths or using fire bellows, that they could potentially help the person. So this is obviously advanced over the years. Now I've got a picture over here on the right, and we've got the guy on the top using a fire bellows, breathing into his friend. We've got the iron lung in the middle, which is what was used during the polio epidemic. And then we've got the Hamilton T1 ventilator on the bottom. Now this is considered to be kind of the gold standard for transport ventilators. It's pretty widely used in the pre-hospital setting or out-of-hospital setting, if you will. So we can see how far this has come. So when we get into talking about ventilators, it's really important that we understand the abbreviations and what exactly it is that we're talking about. So I'm going to get into a few of these right now, and this definitely is not an all-inclusive list by any stretch, but for the sake of having a basic understanding of what mechanical ventilation is, these are by far the most important things that we need to know. So tidal volume. Now, a tidal volume is typically represented with a capital V and a lowercase t. Now, tidal volume is the amount of volume that's delivered with each breath, and it's measured and calculated in milliliters. Now, a respiratory rate, it can go back and forth. Some literature will literally use an R, like an RR, and some literature will call it frequency, or a lowercase f. Now, this is just the rate at which you are breathing for the patient. Minute ventilation, which is represented by a capital V and a little e, is the volume of gas that is inhaled or exhaled from a person's lungs in 1 minute. Fraction of inspired air. So fraction of inspired air, represented as an FiO2, is the pressure of inspired oxygen in the trachea, or the percentage of oxygen that we are giving to a patient. This is the oxygen therapy that we're going to be delivering. So rather than using liters per minute, like we'd see with something like a non-rebreather mask or a nasal cannula, we use a high-pressure system, which is through a 50 psi hose, and this would be represented with FiO2. So positive and expiratory pressure. Now this is PEEP. We all know what PEEP is, but just as a little recap here, PEEP is the method of ventilation in which the airway pressure is maintained above atmospheric pressure at the end of exhalation. So this is the pressure that we are exerting on those lower airways that are keeping those alveoli open, which are going to allow for better gas exchange. Now, pressure support, we're not going to talk a whole lot about this, but there is a section where I will mention it. So I'm going to outline it here. Now, pressure support is something that we use with SIMV exclusively, and it's something that with each patient-triggered breath, a set amount of pressure is applied to that breath that's triggered by the patient to help them overcome the resistance of the ventilator circuit. So now let's get into the modes of ventilation. So controlled mandatory ventilation is a mode of ventilation that's been around for quite a while. It's pretty common still to see this on certain ventilators. A lot of the pre-hospital ventilators that we see that 911 trucks are carrying truly are controlled mandatory ventilation ventilators. This mode of ventilation is often referred to as more of a dumb or unsophisticated version of ventilation, and that's not a shot at the people using it. It's more or less describing the mode itself. So, as I mentioned, this is something that's used in the pre-hospital setting pretty commonly. It's used in emergency departments, and it's used within the hospital as a means to transport patients from maybe the ER to the ICU because it's not as big. You don't have to roll it behind the patient. It's pretty small. You can hook it up to a portable tank, lay it on the patient's lap, and roll the patient to the next room. So what controlled mandatory ventilation is it's a mode of ventilation that it does not recognize any breaths that are triggered by the patient. It focuses on a set tidal volume and a set rate. So we're setting that minute volume, and that's what the ventilator is going to deliver. All breaths are triggered, limited, and cycled by the ventilator, so the patient has no ability to initiate their own breath. This is often described by patients who have been under sedated or required paralysis, that when they were trying to breathe, that it was like sucking on an empty bottle. So in a lot of cases with controlled mandatory ventilation, in the acute setting, it's completely appropriate because these patients are often heavily sedated and paralyzed. So this is an effective mode of ventilation. Now, if we take paralysis or sedation out of the equation, it makes ventilation rather difficult. It'll cause high pressure alarms, and it'll cause patient ventilator dyssynchrony, and it can cause breath stacking, which can be rather harmful. So the next mode of ventilation that we're going to talk about is assist control. And this is the representation AC up at the top. So this is very standard, and it is very commonly used inside and outside of the hospital. It's a very effective mode of ventilation for delivering a set minute ventilation to patients who need a respiratory rest. This is something that we can set the rate and we can set the tidal volume, and it's going to deliver that set rate or that set tidal volume at that set rate. And they're going to be getting those breaths no matter what. The only real difference here between this and controlled mandatory ventilation is that the patient can, in fact, cycle their own breath. Now, when they do initiate their own breath, the ventilator will sense that, and it will deliver the full tidal volume that is set to the ventilator to the patient. So we can see over on the right-hand chart here, we can see the first breath is a ventilator-initiated breath. Now, the second breath here, we can see the patient's triggered it. So the ventilator sensed that the patient took that breath, and now it's going to assist them with the breath by giving them the full set tidal volume. So some of the cons with this is this could be one of those situations where breath stacking could be an issue. If you've got a patient who takes a breath and then there's a scheduled breath immediately after the breath that they took and they don't have enough time to exhale, then they're basically going to get two breaths stacked on top of each other. And this could be really uncomfortable for the patient, and this could cause some serious lung injury. But all in all, this mode of ventilation is most commonly seen, and it's completely appropriate in our setting as well as the ICU. So the next mode of ventilation we're going to talk about is synchronized mandatory ventilation, or SIMV. So this is probably the second most popular mode of ventilation behind assist control. And this is an excellent mode of ventilation that was used originally as a mode to wean patients off of the ventilator. So what SIMV provides a patient is a set rate and a set tidal volume, but it allows the patient to take their own triggered breaths without having the ventilator stack the full tidal volume on top of it. So whatever the patient draws in on their own, under their own power, is what they're going to receive. So in a lot of cases, this is more comfortable. Now, what the ventilator also does is if a patient's taking a breath and there's a scheduled breath right after it, it's going to try to synchronize those breaths so that we're not going to end up with an issue where the ventilator delivers a breath on top of the breath that the patient just took. So for safety and for comfort, this is an excellent mode of ventilation. Another thing to understand is that we use a setting called pressure support, which I already talked about. And so what pressure support does is when the patient takes a breath, it's going to give them a little bit of pressure to help them get that breath. It's not going to deliver a tidal volume to them. It's just going to give them a little pressure in the circuit so they can overcome the resistance that they might have within that ventilator circuit. So with synchronized mandatory ventilation, they often require much less sedation. Obviously, they don't require paralysis. If they were paralyzed, this wouldn't technically be SIMV because the ventilator would be functioning from, in all essence, a CMV mode of ventilation because the patient's not initiating any breaths. So on the right, we've got the graphical representation. We see the first breath being the patient or the ventilator delivered breath, and you've got the second one here where the patient triggered their breath, and it's a much smaller tidal volume than what was delivered by the ventilator. So the settings of the ventilator, where do these numbers come from? So I've given you a couple things here that you're probably wondering if you've never dealt with ventilators before. What is tidal volume? How do we come up with the numbers, and how do we know what to set the patient's settings at? So this is something that a lot of people, in all honesty, don't do. They'll put very generic settings in a ventilator. They're referred to as crash settings, and they'll just leave the patient on these settings as long as they're not getting high pressure alarms or low pressure alarms, and they'll just leave the patient on these until, in some cases, they get up to the ICU where a respiratory therapist can take over the ventilator settings. But since this is a lecture on how to do this appropriately, I'm going to tell you how this should be done. So we should always be doing the math here, and I'm going to show you how. So with tidal volume, so we've already talked about that tidal volume is the air that's delivered to the lungs with each and every breath. So common tidal volume dosing is 4 to 8 mLs per kilo of ideal body weight. So this prescribed dose range comes from the ARDSNet trial, which was something that came out in 2001 that basically promoted lung protective tidal volumes. So we weren't going to overinflate the lungs with these massive tidal volumes. So the reason that we're using ideal body weight, so if we have two people, one person 6 foot and they're 400 pounds, and we've got another person that's also 6 foot, but they're 170 pounds, are their lungs going to be any different in size? And the answer to that question is no. They're going to have the exact same size of lungs. So we use ideal body weight because we calculate this off of the patient's height rather than their physical body weight. And so it's really, really important to understand that. We're not just converting their pounds to kilos and then making their ventilator dosage off that. What we're doing is we're taking their height, figuring out what their ideal body weight is, and that's how we're going to come up with the tidal volume dose. So I'm going to show you a quick example here, and we're going to use the formula here for a male patient. Now, there is a slight difference with female patients, and I'll tell you that at the end. But what we're going to do is we're going to figure out what their ideal body weight is. That's the very first step. So we need to know how tall they are. So an important rule here is that for a patient that is 5 feet or over, if they're 5 feet, they're going to get 50 kilos just right off the bat. And that's a set number. And then for every inch that they are over 5 feet, they're going to get 2.3 kilos for each inch over 5 feet. So if we had a patient that was 5'6", the patient's going to get 50 kilos for 5 feet. And then they're going to get 2.3 kilos for the 6 inch, or for each inch over the 5 feet. So for those 6 inches. So if we do the math here, we've got 50 plus 2.3 times 6, which is going to give us about 64 kilos. Now I rounded this number up, but it's going to be about 64 kilos. So if I want to decide what the tidal volume here is, I'm going to take 6 mLs per kilo of ideal body weight, right? That's going to be right in between that 4 to 8. And I'm going to multiply that by 64. And that's going to give me 384 mLs for my tidal volume. So I just mentioned that it's a slight difference with females. So basically, we're going to do the exact same thing, except for rather than 50 being the set number, it's going to be 45.5. So a slight difference. But all in all, it just goes to show you that there is a pretty easy way to figure out what somebody's ideal body weight is. And understand that this isn't a perfect science. This isn't something I've never ever once seen somebody pull a tape measure out and actually measure somebody. Generally, this is a rough guesstimate, but this gets people very close in the appropriate dose range. So the next thing that we need to figure out is the patient's respiratory rate and the minute volume. So what's really important to understand is that the minute volume is a product of your tidal volume and your frequency, or your respiratory rate. So how you get to your minute ventilation, your minute volume, how you come up with that number is you take your tidal volume and you multiply your tidal volume by your respiratory rate to determine what the minute volume is. But how are we going to come up with what our patient really needs? So to determine what the patient's minute volume needs to be for a very individualized approach to each patient, I want to figure out what their minute volume needs to be. I'm going to take 100 and I'm going to multiply that by their ideal body weight. And this is just for your run-of-the-mill patient. You know, maybe this is a head injury patient that's intubated for airway protection. Now, obviously, this isn't always going to be the case. You see, I've got 120 that we would use for somebody who's in metabolic acidosis, somebody that we need to ventilate a little bit, get a little bit more off of them to keep them from becoming more acidotic. But for most cases, we're going to use 100, and that's what we're going to use throughout the example here. So we're going to take 100, we're going to multiply that by the ideal body weight. So you see that we've got that 64 kilogram patient from the last slide. So 100 times 64 is going to give me a minute volume of 6,400 liters per minute. So now that I've got that, I need to figure out what my tidal volume is, which we already did in the last step, and we came up with 384 mLs, right? That's what they're going to get for each breath. So if I want to figure out what my respiratory rate needs to be here, then I would take that 6,400 and I would divide that by 384, the two values that I've calculated and came up with at this point. And that's going to give me 17 breaths per minute. Okay. And that's also rounded up from, it's like 16.8, but nonetheless, this is what we're going to go with here. And this is going to give us a really close approximation of what the patient actually needs. And as you can see, this is math that you could do rather quickly. You could do it in your head. You could pull your phone out and use your calculator, but you could do this math very quickly and not waste a lot of time. So 2 more settings that we need to come up with here is going to be our oxygenation settings, the PEEP and the FiO2. So these 2 settings, their sole purpose is to provide the patient with better oxygenation. So When we're thinking about adding PEEP, you'll hear some people say to use an approach called the ZEEP approach for certain patients, particularly patients that have conditions like asthma or COPD, where there's already an air trapping type of phenomenon. But in most cases, this is not really going to be very helpful for you because you're not going to be able to keep those airways open well enough to let that gas escape. So we'll generally use a smaller dose of PEEP. You should always use some PEEP. Now, when we sit here and try to figure out what is our intrinsic PEEP, just as you and I are sitting here breathing, what is our intrinsic PEEP? Now, it's been said that it's about 3 centimeters of water. Now, there's some literature that's out there that's challenging that, that's saying that your functional residual capacity, or the amount of air that's left in your lungs after exhalation, doesn't have anything to do with PEEP. But there's been a little bit of a debate here across the board, and this hasn't really changed the literature. So as it stands, 3 centimeters of water is what your intrinsic PEEP is. So when you're setting a patient up and you want to give them PEEP, we need to keep them in a sort of range. So the general approach to this is going to be about 3 to 10 centimeters of water. More commonly, we're starting at 5 centimeters of water. Now, in the age of COVID-19 or patients who have acute respiratory distress syndrome or ARDS, we see these PEEP numbers go way up. And that's generally up to about 20 centimeters of water. And the reason for this is because there's so much that these alveoli have collapsed down to a point that we could give this patient all of the oxygen in the world. Although what the problem is here is that gas that we're delivering to them can't get through those alveoli and be diffused in the blood to deliver oxygen to the body. So what PEEP does is it inflates those alveoli and it really thins that gradient out. And so that oxygen can travel down into the alveoli and it can be diffused into the blood much easier. So this brings us into FiO2. So FiO2, as we talked about, this is the percentage of oxygen that we're going to be delivering to patients. So we know that 21% is what you and I are sitting in this room breathing right now, right? So when we're talking about patients that have, different types of illnesses, what do we need to give them? So generally when we first put somebody on a ventilator, we start out at 100%, then we gradually wean them down until we get them into a good range to where their SpO2, depending on what's wrong with them, is, between 93 and, 99%. We don't really want them to be 100% because we know that we don't really know how high they're going to get at that point. We don't really want to over-oxygenate somebody. So it's really, really important that we keep that prescribed oxygen dose where it's needed, okay? So if you look over here on the right, I've got this chart. Now this comes from ARDSnet, and this is a PEEP to FiO2 scale. So this gives you a couple different options, and this is not something you have to follow verbatim. It's just a recommendation. But we can see that if we're using, and you see the FiO2 is represented as a decimal, but think of that as a percentage. But if we're looking over here, we can see that with each change that we can make a correlating change with our PEEP, and this will promote oxygenation, right? So if you have somebody that can tolerate PEEP well, we obviously know that adding PEEP can make a patient hypotensive by increasing intrathoracic pressure, which is going to reduce preload into the heart. And this can be problematic in patients who are already hypotensive. But for those who can tolerate it, then PEEP is going to be very, very effective. So we'll get back into pressure support. So when we're talking about pressure support in SIMV, a way that I like to think about this is like a BiPAP type setting living within an invasive mode of ventilation. So we've got a IPAP essentially, and then you've got an EPAP. So you'll have your PEEP, and the way that the pressure support is set is however many centimeters of water above what your PEEP is. So you'll set your PEEP at 5, and maybe you'll set your pressure support at 3 or 5. Let's say 5 for the sake of the lecture. So we've set that at 5. So you actually have 10 centimeters of pressure support that's being delivered to the patient, but it's only being delivered to the patient when they take those spontaneous breaths to help them overcome that ventilator circuit so they can breathe easier. And so their natural breaths are easier to take, they're more comfortable, and the patient can ultimately be weaned off the ventilator quicker and easier. So the next thing that we really need to know about ventilators is how to troubleshoot the vent. So this is one of the most important things to understand. And it's really not a difficult concept, but so many people struggle with this. But let's look at the mnemonic DOPE. So DOPE stands for D, displacement of the endotracheal tube, O, obstruction of the endotracheal tube, P, pneumothorax, or E, equipment failure. So obviously the things that are outlined in this mnemonic are going to yield different types of alarms, whether it's low pressure or high pressure, and that's what we're going to get into here next. So let's talk about high pressure alarms first. So one of the most common reasons why you would get a high pressure alarm is that your ventilator circuit would be kinked. So this is an easy thing to do. You should first and foremost, when you get that high pressure alarm, examine that circuit. Is there anywhere in that circuit that's been kinked off? Are you standing on the circuit? Is it kinked in a bed rail? Is there something heavy laying on top of it? These are the things that are going to give you a high pressure alarm. The next thing we can look at is the patient fighting the tube? Are they coughing because they're uncomfortable? What we need to do here in this situation is we need to give the patient more medication to sedate them, but more importantly, give them a medication that's going to treat their pain. Being intubated is very uncomfortable, and having breaths essentially forced down into your lungs is equally as uncomfortable, and it can cause a lot of anxiety. So make sure that you're giving the patients the right medications to make sure that you don't have this issue. Now, I've obviously got paralytics on here. This could be a situation where you may need to use paralytics. Maybe you've got a patient on a CMV type of vent, so giving that patient more paralysis is going to help you here too. But don't ever give paralysis before giving a patient something as a sedative and something for pain. Always treat those things first before paralyzing them. So the next thing here is secretions or mucus in the airway. So how do we fix this? Well, the easiest way to do this would be to suction, right? This is going to give you a high pressure alarm because the ventilator is reaching resistance because there's something that's occluding the tube, right? Those secretions are that mucus. So we need to get down in there. We need to suction that out. So another thing that would cause a high pressure alarm would be the right mainstem intubation. So you've basically put your endotracheal tube too far down and it's ended up in the right mainstem. Now, if we look at the lungs, we know that it's easier for a tube or anything to find its way down into the right mainstem just because of the way that those bronchi have broken off. So if you get your tube down into one lung and you're ventilating one lung, obviously you're giving the full tidal volume to one lung. It's going to give you high pressure alarms. So another thing that can cause this is the patient biting the tube. Now, once again, give the patient something to sedate them, give them analgesic, and this should fix the problem, right? It should, in all honesty, be very difficult for a patient to bite their tube. If we're using commercial securement devices, they all have a bite block, so you shouldn't really run into this issue, although I have seen it. So we get into the reduced lung compliance. So this is something we already talked about ARDS. We get a bunch of basically infected alveoli in the lungs. And so there's this gunk that basically encompasses these alveoli, and it makes these alveoli very weak and brittle. And this is where like PEEP should come into play to keep these alveoli open. But this honestly takes almost 30 minutes of mechanical ventilation to recruit these alveoli to get past this high pressure, okay? And that's with ARDS patients. And this is a very nasty, nasty type of presentation. Now, this is something we see a lot with COVID-19. So that's why a lot of these patients that are on ventilators are so difficult to manage, and why a lot of these patients die, because they end up with symptoms of acute respiratory distress syndrome. So another thing that's going to give us issues with ventilator compliance is a pneumothorax. So a pneumothorax can be caused from trauma, but it can also be caused from things that we do, iatrogenic causes. So that's going to be something that maybe we've overdistended their lungs by inappropriate ventilator settings, and we've caused a lung to collapse. What you're going to notice is you're going to notice high pressure, because you're essentially ventilating one lung at this point. But you're also going to notice the patient's heart rate go up, and you're going to see their blood pressure go down, because that patient has essentially moved into obstructive shock. So how do we fix this problem? Well, we would have to perform a needle decompression on the side of the collapsed lung, and that, in theory, should fix your problem. So when talking about increased airway resistance, we're talking about bronchospasm. Now, this is something we're going to see with our COPD patients, our asthma patients, and the way that we'd fix this is just give them an inline nebulizer, your albuterols, okay? Beta agonist types of medications. Okay, so for low pressure alarms, what we're going to first check is that circuit again. Is the circuit disconnected? If it's not disconnected, we're going to check, you see I've got chest tube leaks. This is something, not super common, but if the chest tube's leaking, that might be a cause. The disconnection from the circuit, anything on the circuit that comes disconnected, it's obviously going to give you this. If your endotracheal tube ends up with a leak in the cuff, that cuff will deflate, and that will certainly cause you to get low pressure alarms, because that there's not as tight of a seal, so that pressure is going to be reduced. So always check your cuffs before you intubate somebody. Now, another thing that may occur is the patient may become shocky. They may become hypovolemic, and there will be a decrease in intrathoracic pressure because of a reduced return of blood to the heart. So this is something that will give you low pressure. You'll get a low pressure alarm from this. So how would you fix this? You would give the patient fluid boluses, and then you could start the patient on vasopressors, and this could correct this. So some physiologic things can happen to a patient as well. So there's definitely a reason why we would need to troubleshoot these. And these are not as much things with the ventilator, but things that happen to the patient. So we know that positive pressure is not normal physiologic ventilation. We know that that's negative pressure, right? So we may find that the patient becomes hypotensive. And this can be done by increasing intrathoracic pressure, like we have already mentioned. And so how do we treat this? With fluids, or perhaps even vasopressors, your Levophed drips, things of that nature, in order to correct that hypotension. Now, as I already mentioned, being intubated is painful. So we should always watch for that hypertensive tachycardic patient, because this is going to be the earliest indicator of the patient experiencing pain or anxiety. And we should always get on the ball and treat this early. Okay, so we're going to get into these practice scenarios / demonstration. And what we're going to do is we're going to demonstrate a ventilator strategy. We're going to talk about how to set it up. We're going to calculate the settings. I'm going to explain the math as I go through it. And we're going to demonstrate how to diagnose and correct a high pressure alarm. So follow along, get your notepads out, practice the calculations, and we'll be with you guys shortly. Okay guys, so what we're going to do here, we're going to do a quick demonstration just on how to calculate ventilator settings for a patient, the initial ventilator settings, okay? So we've walked into a room, perhaps they're already intubated, maybe we intubated the patient's receiving bag valve ventilation. So we go in, first thing we need to do is determine the patient's height, okay? So we've done that, the patient we've estimated to be about 6 foot tall. Okay, so what we're going to do, I'll move to this side so you guys can see a little better. We're going to give that patient for the first 5 feet 50 kilos. Okay, so that patient's going to get 50 kilos. So for that additional 12 inches that's over that 5 feet, they're going to get 2.3, right? So that's going to be roughly, and I've done the math already here, guys. I don't have a calculator out. I'm not a brainwaz of getting this that fast, but it's going to be about 27.6. So we'll add 27.6 to that. And that's going to, okay? So the next thing that we're going to do here is we will take that and we'll multiply it by 6. Now remember, the reason we're using 6 is because that's right in the middle of ARDSNet recommendations on that 4 to 8 mLs per kilo tidal volume range. So we'll multiply the 78 by 6, and that's going to give us 78 times 6 will give us roughly 470 for a tidal volume. So that's going to be our tidal volume. Remember, represented with a capital V, lowercase t. So the next thing that we're going to need to do, so we've got that 78 as their kilos. We need to figure out with their ideal body weight what their minute volume needs to be. So remember, for the minute volume, capital V, lowercase e, we're going to take 78 and we're going to multiply that by 100. And that is going to give us 7,800 mLs per minute. Okay? So we've got 7,800. So now that we've got the minute volume, now we want to figure out, we know the minute volume, we know the tidal volume. Now we want to figure out what is our patient's respiratory rate going to be. So we'll take that 7,800 and we'll divide that by 470. And that is going to give us a respiratory rate of 16.5 something. So we'll round that up to 17, okay? So that's going to be 17 breaths per minute, or a frequency of 17. Okay, so those are our settings. The next thing that I'm going to do here is we'll take and we'll plug these settings into the ventilator, and I'll show you just kind of roughly how I'm going to do that with the ventilator that I have here at the base. Okay? Okay guys, so what I have here, this is a Revell ventilator. This is made by CareFusion. Now this is a very commonly used ventilator in the transport environment. So we see this a lot with air medical crews, with ground ambulance crews. While this is not a review of the ventilator, I can attest to its use. It's very good. It's pretty user friendly. And so this is what we're going to be using for our demonstration today. So forgive me if any of this shows up inverted. I hope that it doesn't. It should switch things around, but it may show up and be slightly inverted, so please bear with me. So the first thing that we would need to do is we need to turn this ventilator on. So it's going to go through its power on phase. I'm going to silence the alarms here. And so I'll set this straight up. I'm going to get my ventilator circuit. So we've got the circuit here. This is what a circuit looks like. It's basically just a long section of hose, and we're going to plug that into the side of the ventilator. You see there's a couple little ports here on the side. I'm going to plug it in. There's a couple smaller connectors that we use as a flow sensor, and they can give us pressure sensor feedback as well as blend oxygen to the circuit where the patient's going to receive it. Okay, so we've got that hooked up to the ventilator circuit. Now I've applied a test lung, so that's what we're going to be using for today's demonstration. I'm just going to set that down while we show you what we're going to do. So it gives me the option up here at the top. I'm going to go over to new patient. We'll hit select. We're going to go to patient size. I'm going to select adult, and he's intubated, right? So it's automatically going to start ventilating. So it's important that we don't hook this up directly to the patient right away. And the reason for that is because I don't want to start ventilating the patient with whatever's stored within this ventilator. So I'm going to get my settings correct here. And so we decided that our tidal volume was going to be 470. So I go up here and click where the tidal volume is, and we'll go down to 470. I'll select that. And then we're going to take the rate up to 17. And so if that rate was multiplied by the tidal volume, that's going to give me a minute volume of 7,800 milliliters per minute, or 7.8 liters per minute. Okay, and that's well within that range of the 4 to 8 liters per minute, like we talked about. So the next thing that I would do here is, since I just hooked the patient up to the ventilator, we really want to take this, and this is going to alarm, guys, and the reason for that is because I'm not hooked up to an external oxygen source. So I'm taking it off of room air. We're going to take it up to 100%. It'll take me a second here to get up there, but we're going to take it up to 100%, okay? And then the next thing that we do is we take our PEEP, and I'd probably start that PEEP somewhere around 5. So pretty simple. This would be a good way to set up your ventilator for a patient who perhaps has sustained like a head injury. They don't really have any real respiratory component, such as like an obstructive type of process, like your COPDs or your asthma, or a hypoxic type of issues, like perhaps your CHF or your pneumonias or your ARDS. So this is going to be mirroring close to normal physiologic respiration, aside from the fact that they are getting positive pressure. Okay, so pretty simple stuff as far as setting this up goes. Okay, now quick demonstration here. So if I were to in any way impede the flow here, you see I'm going to get a high pressure alarm. Now what the ventilator's sensing is that I've got a decrease in compliance somewhere. So the first thing that I would do is I'd come down and I check this circuit. Now you can see it's relatively long, and especially when you put it inside of a vehicle or there's a lot of providers nearby, there's a high likelihood that this could get kinked off and it could cause this high pressure alarm. So I'm going to examine my circuit all the way up to the patient and all the way up to the ET tube and make sure that that circuit is in the right spot. And so if all of that checks out, we're going to listen to lung sounds. We're going to make sure that it's nothing on the patient side. We're going to confirm that there's nothing that's obstructing the tube, such as secretions. And then I'm going to look over at, and if I don't hear wheezing, I should hear wheezing if it's a bronchospastic type of thing. But if I can't really hear anything, then we'll go over, we'll look at our end tidal. If we see the shark fins, then we'll just go ahead and give the patient a nebulizer. And then, as I mentioned, if you need to suction the ET tube out, we can obviously do that as well. Okay, so that's for a high pressure. Now I know that I just said that we were going to demonstrate a high pressure, but let's do a low pressure while we're here. So say I take and disconnect this. So now I've got a low pressure here. It's going to say patent circuit. This ventilator will actually cue me in and tell me that it's likely a circuit issue, but I'm going to get that ding. So that's where I'm going to go, and I'm going to check my circuit, make sure everything's connected. I'm going to make sure that there's no cracks in the circuit, and you can see this would be pretty easy if it were to get stepped on or smashed. This could break. It's corrugated, it's relatively tough, but out here in Iowa we work in some relatively cold environments, and I have seen these break in extreme cold temperatures, so it is a possibility. So we'd check that circuit, we'd go to the ET tube, we'd check that ET tube depth, we'd go ahead and we would examine whether or not that ET tube's dislodged. We could go ahead and listen to lung sounds again, make sure that it hasn't come out, and we are just going to kind of go down that line there, make sure the patient's not hypotensive, and just check that dope pneumonic. So as you can see, if you can do this in a systematic way and start from the ventilator circuit all the way up to the patient, we should always assume the worst, because that's the thing that's going to catch you the most off guard, right? So we should always look for the worst type of things first before we start blaming it on the machine. Okay, that's why you notice that the equipment's clear down at the bottom. But when we think about what happens most commonly, such as something comes disconnected or something gets kinked, then we're going to end up with these issues, okay? So this was just a really quick demonstration. I know that this whole interface right here is going to be a little bit different than what you would expect here, especially if you've never seen this before. But just so we have a general working knowledge of kind of, or that we can put the face of some equipment to what we've been talking about today. That's why we included this portion here. So thank you guys very much for watching this portion. So we'll kind of wrap this up right now. Okay, so in conclusion, mechanical ventilation is a very important part of emergency critical care and even interfacility transports, as well as the pre-hospital environment. This is something that's very, very important to patient care. And this is just to maintain a steady, consistent mode of ventilation for patients in a safe fashion. Now, naturally, this is an aspect of medicine. This is using a automated device, so there are inherently going to be some dangers associated with mechanical ventilation. So it's very, very, very important to follow the steps that we presented today to make sure that we are creating patient-specific ventilator settings that are going to be not only safe for the patient, but effective and catered to them in particular. Now, this is obviously just a introductory lecture into mechanical ventilation. There's a lot more stuff that we can really get into with mechanical ventilation, and we can really hone in on and perfect our skills. And especially when we're talking about different patient presentations, there's a lot more to this, guys. But just to get a general understanding of the fundamentals of basic mechanical ventilation, I think that this lecture really did highlight some of those areas. So this can obviously be very intimidating, right? Now, we've talked about how there's math involved, there's obviously dealing with an intubated patient. So all of this stuff can be rather intimidating, but if we practice and we make sure that we're following these steps, this is going to cut out at least one portion of that stressor and make things a little bit easier for you. So hopefully, guys, this helped you to have a little bit better understanding and a little bit more working knowledge on how mechanical ventilation works and how important it is. And I really hope that you guys learned something. Thank you guys very much for watching. If you care to look at the sources, here's several that I listed that are very helpful and some that I used in making this presentation. Thank you guys again for watching. I hope that you guys have a really good day.